Is myself, Dr. Musman, going to be speaking with you today, just to give some ideas about the MRCGP Part 1 exam. Another word is AKT. So in the AKT, how to prepare. And I believe some of you a little bit oriented and some of you may be very, very beginner. So in the world, any exam of the postgrad in the medical field have some specific orientation. Though the knowledge is the same, but how to prepare ourselves, this is very important regarding your time management, everything. So today I will be talking on behalf of our institute, Dr. Usman Academy of Medical Sciences. And these are sometimes our materials are actually a little bit restricted, but this is almost a free session, so it may not be more problem to share with others as well. The permission already given for everyone. So tips and tricks, what I mean actually here, that the profile of the exam, profile of the question in the exam, you know that there are very popular exam in the world. One of the MRCGP, another is the MRCP and the specialist medicine exam. Some licensing exam in the world, USMLE or the lab exam, Australian Medical Council. So our research, our observation told that the questions are almost same, but in different format and different presentation. And the very, very important thing is in this type of exam is just to deal the patient, not the knowledge. So always we will be thinking a patient in front of us and what I'm thinking about the patient regarding the patient's diagnosis, further evaluation and management. So what I like to share first that possibly all of you, whether to say planning in future, your MRCGP AKT exam plan, this is just a routine. You can get into the website, the 2022 exam routine is here. So if I say that 2022 AKT exam remaining only one time in the November coming, and time is very short. So I should pray the best for all of you, those who are appearing the exam. But today's class is not for the exam preparation. Mainly, it is just to give an idea what is AKT. So it can be helpful for the very beginner to almost the mature examiner as well. So this November 16th exam, already the registration closing date is over. I don't know how many of you registered for them. Anyway, so these are two exams in the year usually for the AKT and OSCE also to exam the clinical part. So if I proceed further, if we start with the applied knowledge test, this is the AKT, this is 200 single-based answer questions. So if I show you one example, you will understand what is the question pattern. But the main concept of understanding, especially in the South Asian exam or even the MRCGP UK, the informations in the exam, the patient's data in the exam, based on the context of the region. Basically, in broad heading, there are two regions rather, to different pattern of questioning. One is the MRCGP UK, another is the MRCGP International. And in that international, there are some other countries, those who are having separate exam, but almost the broad heading, one for the UK, another is outside UK. So suppose if South Asian exam is mainly based on the South Asian people pattern, but one thing is very clear that the diseases are not 100% different or 99% different from each other from country to country. But there is some social epidemiology and other issues as in different areas of the country. For there's some little difference rather to say. So if we prepare for the AKT or MRCGP Part 1, or even for the MRCGP South Asian, it can be helpful for the preparation for MRCGP UK as well. And we have this experience also. And it is found because that I said before the almost similar profile of exam in UK and outside. The reason is that the core question, core clinical medicine occupied almost 80% of the examination questions. So those who prepare for the medicine exam, rather, suppose what happened in our life also before that, we were preparing for the PACES exam. With this preparation, with a little extension of the preparation for specific preparation for the MRCGP, we become actually successful. The reason is that the 80% question comes from the medicine, clinical medicine. So if you prepare for the 80%, your pass mark is not definitely 80%, it is less than that. So it is very easy to pass really. We must know it. And the other than 80%, the remaining 10% you see from the evidence-based medicine, that is the core of development of medical science. Actually, we shouldn't bother about the details of that. If we face question, we will understand. And then ethical legal issues in our practice is around 10%. So if you say main bulk of clinical medicine and others. In the clinical medicine, not that internal medicine or I like to say, there are some general surgery, some gynecology also. So all together cover the 80%. Women's health, I will show you the details. And from there, they are saying that the almost equal burden, not burden, rather to say the equal amount of the question come from each broad system. Suppose broad system is the cardiovascular, respirology, like that, almost equal numbers. They divide the 200 questions into these systems most. And there are some few other small systems, rather to say, and these are also important, we should not ignore it. So this is very important thing, the medicine related, the GP is doing in the chamber. It is not mainly from the surgery or other skill-based subject. Okay. And each group, that means the system question will focus the disease factors, that means the risk factors, presentations means symptoms and the signs, the further evaluation by the investigation and the management plan. And definitely management plan will not be the validity. As a GP, what management should be in our mind in a GP profile, that will be asked in the exam. So if I proceed further, doctor, you just see the topic written by the Royal College of General Practitioners. These are a very big, the list from there, we have selected this part for the general practitioners. So you see up to this one already we have, we will show you also in our class routine later, only to see detail I talked about. And the underlying another philosophy, the question setters feel when they design the questions. Some common condition, but low impact. Suppose so true is very common, but the clinical impact is not too much severe. They are a common group. Another one, the diseases are not much common, but impact is very severe. One example is the meningitis. So meningitis is very important, like similarly from other system also, you have to think. A subtopical, that is the separate thought process, work in setting in the question by the question setter, the regulation of the drugs or others. The topical means the local problems. Suppose in the South Asian people, the pattern of tuberculosis, its evaluation and the management is different from United Kingdom. So these are the local problem. And the local problem more relevant and more prevalent. And the South Asian peoples are the respiratory tract infections as well as the diarrhea. These are most valuable topic in the MRCGP, international or rather to say South Asian people like this. So these are the areas of the subjective encompassing the exam. And it is actually, you see, unlikely to encounter question about the management of diseases which are rare and which will be treated by the specialist only. So, but GP is to know about the disease and its management pathway, management tracking, right? But the treatment be given in the secondary or tertiary level. Okay. Now, the referral materials we have to follow. A big list given by the College of the General Practitioners. But in our candidates, we advise and prepare mainly based on this. We advise that have a book of the British National Formulary and the NICE guidelines, already possibly, and the RCGP Essential Knowledge Update, you can get the link. But all the things may be covered almost 80 to 90% from a book, small book. This is in the Oxford Handbook of General Practice. Now it is running 5th edition. So I hope all of you having the book. If you don't have, we can provide to you also this edition as a PDF. You can send the request to our WhatsApp. You can inbox us, our office WhatsApp number. So this is the book. So don't be worried, doctor, that you need a lot of book, but book not the matter. Matter is understanding. Now come to understand some sample questions. So if it is a question, I will be happy, doctor, if you can interact with us and you can raise the hand to give of such questions, and by reading silently you can read, or anyone can read by voice. Don't feel shy, and then don't be embarrassed also. What will be the answer? It is for understanding. Just giving a sample of the question. What will be the answer? Please, anyone, please raise your hand. Please raise your hand. It is better. Or you can unmute by yourself also, respond. Spontaneously better, doctor, so that your session will be fruitful. Anyway, in short, the 58-year-old lady, right? These are the problems. And in this question, doctor, what will be the answer? If I show you the 4 messages from the scenario. Pfizer, sorry, possibly you wanted to answer? I couldn't see Dr. raising hand for that. Anyway, Dr. Pfizer, are you thinking this will be the answer? Dr. Pfizer, please. Is what?
And I think E.
E, you are thinking E. Start treatment with a calcium channel blocker and review in 1 month. Yes, if anybody interact also, it's better, but I can interact with you, Dr. Pfizer. First, thanking you that you have responded. You see, this pressure is very borderline high, I have to say. And patient does not have any risk factors. Patient does not have any complication of hypertension right now. Very first time you are facing, right? So these are the core messages, how to prepare with the treatment plan for the hypertension. So first, we need to be confirmed that patient is hypertensive. For that, according to the NICE guideline, we have to advise for ambulatory blood pressure monitoring. And it is found that if it is still high enough in the ambulatory blood pressure monitoring, then we will level. If I come to a slide from here, it is written in the book, and actually it is extract of the NICE guideline. I will not detail too much here. You see that the pressure is a clinic blood pressure. You are checking the blood pressure at your clinic. If it is more than 140/90, even it is in the more than 150, 160 also. If no other background of risk factors, cardiometabolic risk, and the target organ damage, we need to advise for ABPM. It depends upon your decision, doctor, but this is a guideline, only guideline. And for passing the exam, we need to follow the guideline. But we can do in our chamber with some little modification also. It's also true according to the situation of the patient. So this is the answer, doctor, here, ABPM, and there are some values. Then you will decide that this is hypertension, then you will give the medicine. But I know, Dr. Faiza, what you have given the answer, because at the age more than 50, the drug of choice will be the calcium channel blocker. You are very right. You are very right, but we need to be sure. So these are one type of preparation, right? Whatever you read in the book about the hypertension, you will not be able to answer the question. Now, the second scenario, 30-year-old man presenting with the sneezing, nasal block, and constant running also. This question from the respirology, and what will be the answer? There is a, what will be the answer means we need to be very serious about the instruction that not have a role. Sometimes to test the attention of the candidate or doctor, they use the word not have a role. So all drugs having the effect, but other than the oral decongestant. So sometimes we use the decongestant, but actually the main effect is not by the decongestant. It is very, very temporary effect. The disease is allergic rhinitis. It is not the clearance of the nasal passage. For that, there is a tricks of the question. It does not have a role in the allergic rhinitis. So as allergic rhinitis is a disease, we have to give the anti-allergic medicine. Okay. And this is the description of the allergic rhinitis. Your question bundle will have such thing. You need to read for this. If I come to there, Dr. 3, if anyone have a look, and if you want to react, doctor, it's better. Otherwise, I'm reading for you. 67-year-old male presented with dyspepsia, and it has started 2 months. And you got the history that patient lost weight. In the examination, you found the patient pale and some angular stomatitis also. So stomatitis means there might be some nutritional deficiency or other form of the infection in the lips. So now, what management plan? If you think that for the dyspepsia, I will give the PPI and other relevant treatment, you may not be right all the time. Our responsibility to identify some bad news here, doctor. See that he lost the weight, patient is pale, that means patient is anemic, having other stomatitis feature. So your duty will be referral, not give any medicine right now. So these are different attitude or different technique of answering the question, doctor, in the IKT exam. If you found that there are some called the alarm sign, I am just giving you one by one. You can see one by one in the corner. So how to remember this? The technique to remember. It is called the alarms. Alarms by the mnemonic. If the GIT symptom associated with those features, it is called the alarm features. And alarm features needs for further evaluation with endoscopy. Although this is an invasive procedure, otherwise we would be so. You will not be treating this under endoscopic findings condition, but we need to refer the case to appropriate channel. So this is another type of GI disease. We have given you an example, doctor. The mnemonic we designed is alarms 55O. That is the age, and the esophageal problem also there. So this one, and if we found like that in the exam, doctor, you will face some questions like these, having the picture. There may be other picture also, ECG and other for the procedures, but now the clinical picture of such patient. What you are thinking seems to be Cushing syndrome, and they have said that this is a Cushing syndrome with some features. Now, question is, what will be the most initial investigation, appropriate initial investigation? Whenever you know, doctor, please don't be shy to raise the hand. I will give you opportunity, but let me talk in my own way. So the first test will be the Cushing syndrome. And all of you, or many of you possibly know that the treatment of the Cushing syndrome will be dealt by the endocrinologist. If I say that I'm a GP, why should I know the endocrinology or the Cushing syndrome? The thing will be that as a first physician, we need to know about this disease, minimum the diagnostic feature, and to confirm the diagnosis. Most of the cases, this is the GP's role. And the GP actually suspect the disease, and some diseases specialists must have role to confirm the disease. So this is a Cushing syndrome we need to suspect. So we need to have the knowledge of this Cushing syndrome also. Anyway. And another picture, doctor, you see, this is the skin lesions. Can anybody give the answer, doctor? A young female presented with the itchy rash here, you see. Here means this is important, the area, location, and happen in the few hours duration. That means the immediate reaction in the skin happened. When the patient was walking in the garden or working in the garden. And she had a similar rash before also. So patient having allergic tendency. So what could it be? By looking the picture as well as the background, how it happened. Somebody may tell the allergic contact dermatitis, folliculitis, or herpes zoster. There are some blisters also for that. Anyone having any idea? No. So let's see. This is the allergic contact dermatitis. Actually, doctor, I'm talking something from the dermatology. So these are very common in GP practice. And this is the touching of the, I think some of you might have the experience in your life when you're in your childhood moving here and there, in touch with the leaf, the people having this itching, rash and others. Sometimes in our childhood, we are disturbing to other also by the leaf, touch with the people. So this is one the dermatology. If you come to the neurology, some question, you see, sorry. Before going, this is the question, the TIA, what investigation you will do? This is the question, the single most appropriate investigation. Again, whenever you diagnose the case, you are not treating right now. you will send to the appropriate channel towards the neurology clinic or dedicated stroke clinic, whatever. So if any, the monocular blindness, it is called the ocular TIA, the focal problem of the nervous system. So most TIA, the source of the embolus is the carotid artery. So your job to know about the carotid Doppler ultrasound. If you don't know or you are not oriented at all with these words even, you cannot give the answer. You will be confused. These are very common, but unfortunately may not be available in all GP setting in South Asian people. But many where in the district level or national level, this is available. So we need to know and we need to refer. This is another neurology case. There are a lot of questions in the neurology. Today, just to give you some touch of the scenarios, doctor, those who are planning to prepare the exam. And this is another one, Dr. C. The again 60-year-old male. He was referred to the episodes of vertigo last 4 hours. Very common vertigo problem in the general practice. And associated other features also there. And on examination during an attack, having the nystagmus patient having on the right-sided sensory neural deafness. So I believe that all of you know this, what the symptoms and the signs are here. So deafness, nystagmus, you know. So in the 6 years old, what could be the diagnosis? Some may say that the benign positional vertigo, some may something else. So if you concentrate there, doctor, this lasts up to 4 hours, pressure in the right ear, the sensory neural deafness. There are some nystagmus as well. The all features are not needed to understand. Some 2-3 features enough to reach a diagnosis. This is the Meniere's disease. There are some tricks to remember, doctor, of these vertigo. If it is a matter of minutes and the hours, this is Meniere's disease. So this is the hours features. And sometimes benign positional vertigo, another name is paroxysmal positional vertigo. It is a matter of seconds. So there are some tricks to know about this. So I'm giving some highlights or topic in the MRCGP. The paroxysmal lasts for hours, minutes to hours, likely with associated other features. Now another picture to show you. This is from the eye diseases, and this is a little challenging for the profile of AKT. And if I like to compare with the MRCGP Part 1 exam. Usually in the exam, they don't give any picture, but MRCGP, they give the picture. This is an extraordinary issue in the AKT preparation. In the eye, there are some common ophthalmologic presentation in the fundoscopy. In the OSCE exam, that means the practical part also, they will give some pictures of the retina. This is the fundoscopy. I don't know how many of you understood this picture. Can anyone say, please, what may be underlying diagnosis of the picture? Dr. Faiza, can you try? Other colleague, Dr. Sarah as well. It is very important and interesting as well. If you think nothing, so let me say my answer. Answer is combined oral pill, contraceptive pill. But thing is, what is underlying disease? This is first. Before advising any medicine or any cause identification, what is the disease now? To say the patient is on medication for the acne and contraception. So acne, as a dermatologist or GP you are treating, subsequently found that patient developing headache. So without any other features, it could be the drug-induced internal retinal problem, and the finding is the papillary edema. This is the papillary edema. The optic disc margin is blurred. Otherwise, the retina is okay. So these are the simple features, and we must know to pass the exam. If it is the papillary edema, it is called benign intracranial hypertension because it is not associated with other problem. More likely background is the treatment of the acne as well as contraception. So contraception means this medicine, combined oral contraceptive pill, can produce headache and can produce such a retinal problem. So my suggestion is to know about the fundoscopy, and these are the link, doctor. If you want, you can request the link to us. We have the lecture and discussion of the fundoscopy session. So it is not the time to talk more. And we can provide a PDF also of the fundoscopy because you will face few questions from fundoscopy in your AKT exam. If I come to doctor, the next one is student worried she may not be able to take her final university exam. because she says become frustrated, faint, dizzy when she has the written exam. You are thinking it may be functional, psychiatric, or psychological issue. She does not have any other symptom, any other time underlying, and including when undertaking sporting activity. So during time of the pleasure, she doesn't have any problem. So what you will do? What you will do, and what you are thinking underlying issue? Anyone, please? Okay, I'm proceeding with this. This is a functional disease. Maybe she's suffering from anxiety disorder. I don't know how many of you do this, or you are having the, let's say, the intention to give the medicine, maybe diazepam, fluoxetine. No, as a GP, your priority will be arranging the counseling and some relaxation training or the technique. So if you don't understand such questions, you will not be able to understand, you will not be able to answer correctly in your exam. So this is the way, doctor, to read the question. Possibly you are having some bundle of questions with you, maybe 1,000, 1 or 2,000. We have provided to our candidates. But we need to understand in this manner that what will be the key messages are here. So stress, anxiety, non-pharmacologic treatment is the priority expected answer from the general practitioners. And this is a case from GI tract disease, undergo endoscopy, and being advised by the GP for the indigestion, dyspepsia. You found duodenal ulcer and the Helicobacter pylori was found positive. What will be the treatment? So before going to the treatment, any drug allergy background is important. In the last few days, doctor, we are going for the osteo orientation. And in the routine question, drug allergy is mandatory to ask. Suppose if you know the regimen for the H. pylori, the amoxicillin, clarithromycin, and another one, PPI. So a very standard one. But if you have the history of allergy to the penicillin, you cannot choose amoxicillin. You need to choose another alternative medicine. If you think that I'm a GP, why I will be knowing this thing? But doctor, to treat the patient by knowing only medicine is very simple. If you are reluctant, you will not be able to know. But if you be busy with very complicated scenario for the diagnosis and management planning, it will be difficult for you. But it's very simple to take the drug history, and it is found in the general practice. Actually, doctors are not taking the proper history, including the allergies to the drug. For that, this type of question common in MRCGP, so MRCGP AKT example. So what will be the answer? The core message here is allergic to penicillin. This is the keyword, the most important keyword. So the alternative will be the omeprazole, and there is some other issue also, doctor. Omeprazole 20 milligram, metronidazole, clarithromycin, right? So metronidazole, not the tetracycline. So there's some milligram issue also. Other than omeprazole, any PPI we can select, but milligram also we must know during prescription. So to write a proper prescription, what may be the milligram? Not for all diseases, doctor. Few common diseases we must know, especially tuberculosis also. And in the yesterday also one colleague shared his opinion that in the OSCE exam there was a question, the surrogate, you know the surrogate word, the dummy patient is giving a question to the candidate that the doctor, I have a tuberculosis and I want to have the 4-drug medicine. You know the 4-drug regimen for tuberculosis. Doctor, give me the prescription with actual dose of the drug. So it is not relevant for all the diseases, but those diseases are very common in the South Asian zone. Especially, you see the peptic ulcer disease most common, not in the South Asian, throughout the world. Diabetes, hypertension, the infectious diseases, the tuberculosis, these are common throughout the world also. So, but more prevalent in South Asian or in the low profile economic countries. So for common treatment medicine, we need to know the dose also, doctor. This is the message. So a short break now, doctor. I don't know, will you ask me any question? If you want in the meantime, you can raise the hand, and otherwise we are switching, doctor. Okay. So if we start we'll be finishing within a few minutes, doctor. I'm showing some different patient scenario from the different system. For the time, taking a little time. Later, I will discuss some technical point of view, how to proceed further according to your timing for the exam. Some of you may be appearing or not. So I will divide the two group of you. So this is now another 60-year-old immigrant asylum seeker having the severe pain in the grade 2. And the metatarsophalangeal joint is hot, warm, and exquisitely tender. That means too much tender, and is an acute problem. And he is under care of a local chest clinic, treated for the tuberculosis. What is the reason of this joint problem? Can anybody guess? And it will be your patient, doctor. Yeah, patient. You may diagnose the tuberculosis. You must send the patient for the tuberculosis clinic. This is the reality. And the tuberculosis clinic will give treatment after further evaluation. Then they will send back to you for the follow-up. In the follow-up time you got after the treatment, he's being treated for the tuberculosis. So which drug causing such problem is very important, doctor. Please, can you like to share, please, anyone? Anyone? No? You are, I don't know, being silent, man. The lesson today. Anyway, so you see, this will be the picture, and answer will be the pyrazinamide. Among the tubercular drug, pyrazinamide have the strong propensity to raise the uric acid and produce the joint problem as such. So just give some technical point of this question. Doctor, you see the question actually from where I have collected, they didn't give the picture there. What they have given, they have given just the description, If you know the topic, it is easy to understand the description. But when you think that it could be the gout or MTB joint problem, and another time is the podagra you have seen in the book. So why not go to the internet, the YouTube or internet Google image doctor? It's a technical suggestion for you. Immediately look at what's happening with the picture. So picture will tell you a lot of things. So try to understand with the picture. It's very important for your learning, not only reading the text, doctor. This is an additional suggestion for you. And this is the gout, and another one, doctor, alcoholic, drug related. The number one is the alcohol. And there may be some overdose also in the system. And you see the patient alcoholic dependent for the many years, present with the double vision, confusion, unsteady gait. So patient now have some bad outcome. And the memory also is in trouble. So patient is in the danger of the alcoholism. So any vitamin having some role which a GP immediately can give. And what is this? Can anyone please? Anyone please raise the hand? Doctor, do you think that I will be talking by myself only? Huh? Please share. It will be good if you can share, doctor. Right. So immediately we can give the thiamine. This is the vitamin B1, and it is mostly deficient in alcoholic people. So it will be saving. And another tricky question, doctor, of this, that patient having become unconscious. So it may be the hypoglycemia also. If you don't have CBG machine, glucose measuring machine with you, so we will give thiamine as well as sugar also as well. Right? Glucose drip, remember it, doctor. So I'm not detailing this. I'm just touching a question from the drug-related question in the MRCGP. So the underlying diagnosis was vernix and encephalopathy, and urgently needs B1, urgently. So it is your job, doctor, to give. Now come to the next patient. Patient is a baby, pediatric. Patient presented with a pallor, followed all the scenario, doctor. Pallor and the gland enlargement, that means the lymph nodes. Gland means lymph nodes, cervical lymph nodes. Unwell for the 3 weeks. All babies, it is called the background history is the BIND, B-I-N-D. When we go through the data, collecting the data of the baby, we must know about the delivery issue, birth, that means the birth, BIND. I is the immunization, N is the nutrition, and D is the development. So baby does not have any problem during delivery in the neonatal period, immunization up to date, and no any congenital problem, because no family or social history of no surrounding, social background, social deprivation are not there. These are very common part of the history, and all general physician, family physician must know about when we deal a patient of the pediatric age group. But patient having the positive information is the paleness and the glandular problem. That means cervical nodes. Some bleeding, neck, in the neck and the palate. So in examination, you found that the patient presented with the neck. This is the layman term, doctor. Just to add something. In communication, the scale, though I hope all of you will pass AKT later and will go to the OSCE. When patient talks, they talks in the layman term. In your AKT also, some layman terms are used. Marked gland enlargement. If you ask that which gland, is it parotid gland? It is other gland? No, doctor. Usually gland means cervical lymph nodes. Sometimes neck glands indicate the thyroid gland also. So pallor gland simply means cervical lymph node. So in this patient, febrile maybe or may not be. Bleeding is the problem is there. And the generalized lymphadenopathy, what may be the possible diagnosis? So lymph node in the young baby, more likely diagnosis will be here is acute leukemia. If we are not able to understand it, if you think that okay, pallor, give the blood and some hematinics is not enough. You have to consider this anemia and the thrombocyte problem. Patient is maybe febrile also. It may be underlying free cell line disorder in this question selected from hematology. So it's a very dangerous diagnosis. If I am not able to diagnose, so patient will die in your hand, in my hand also. And one thing, doctor, if I ask you anyone, what other clinical examination sign to be revealed in this case? Though it is not mentioned, not important as well. We are seeing the anemia, jaundice, routinely. In some cases, in the respirology, cyanosis, clubbing. What else in the neck, doctor, other than lymph nodes near the neck? Can anyone say, doctor? You have an idea about the bone marrow disease? Sorry, doctor, if you don't know, very difficult for you to appear the exam very short time, doctor. You need to take some time also. I think you know the sternal tenderness, sternal tenderness or bony tenderness. So we are pressing over the sternum. Actually, you are touching the bone marrow because the sternum surface, the bony surface, is very thin rather than other comparison to the other parts of the body, other parts of the area of the bone. So if you press over the sternum, you may find that there is a tenderness. Though it is not mentioned here, the thing is that these 2 clues or 3 clues are enough to diagnose the case. So these are the tested in GP exam, doctor. Take care. So the clue is that you see pallor, pyrexia, and the petechiae, the 3 P's in this pediatric age group. So this is a malignant case, and the lymphadenopathy indicating the lymphoblastic leukemia. And the mediastinal lymph node, then you will check the chest X-ray to see the mediastinal. It's extended, doctor. If you found the mediastinal lymph node, so you can have an idea that it could be in the lymphocyte, though. That means a lymphoblastic leukemia. It could be T cell leukemia. There are B cell leukemia and the T cell leukemia. It is not actually must be a known issue as GP. You know, the learning process will be must be known, better to know, fine to know, like that, divided the 3 tier of the learning process. So this is beyond this, but must know is the 3 PPP. Pallor, pyrexia, petechiae. In a patient, we must think of leukemia. Anyway, now another one question from infectious disease. This is a terrier and dog, one type of dog. It is actually added by ourselves to understand the question better. This 25-year-old male bitten by a dog. This is a terrier. One is vicious. There is an wound, swelling another. So after wound is cleaned and received tetanus. Tetanus must be given for such injury. What antibiotic do you need to choose? Can anyone having the experience in your life, doctor? Doctor, anyone?
Yes, A.
A, right. If I ask you, Dr. Khan, thank you to give you answer. This is the A and you are very, very right. So I like to congratulate you. Doctor, have you experienced or heard any person bite any person? Human bite? Have you heard it?
Yes.
Yes. So Dr. Zainab is here also. What will be the treatment if bitten by a human?
Same, doctor.
Same?
Coamixiclav.
Fantastic. Yeah, I think Dr. Zainab is ready to appear at the exam. Good. The same really, same. Amoxiclav. So these are very simple questions, right? Human bite and the dog bite is very common. or any animal bite. You understand the treatment plan is almost same. Now, this one, correct concerning the oral polio vaccine. So one simple question from the immunology, a little bigger chapter, different. There are some popular questions. What is the live vaccine? Contraindication of the live vaccine. So in this orientation class, Doctor, with the shorthand, I cannot detail it. We have to discuss in other, maybe the bigger courses. So one question is like oral polio. You know that this is live vaccine. If it is the live vaccine, so answer will be, it is a live attenuated vaccine. And these are not correct answer. It's very, very simple question, like a direct question. For immunology, we need to know the vaccine schedule also. And now another one, 26-year-old man will come to the GP with urethral discharge. Whenever urethral discharge, you are thinking that it may be the sex-related disease, sexually transmitted disease. Very interesting, doctor. You can look at the question. And what we do some investigations, the smear, microscopic exam, and very easy, by the gram stain, you found gram-negative intracellular diplococci. So what may be the name of the organism? Can anyone say again? Dr. Zaina, please. You need to be hurried and to give the answer, doctor. What may be the name of the organism? If it is a gram-negative intracellular diplococci in the urethral discharge. Can anyone? You forgot the microbiology. Whatever. You see the intention of the examiner
Neisseria
here.
gonorrhea.
Fantastic, Neisseria gonorrhea. Why they did not mention the name of the organism? It is expected. Psychology, philosophy, doctor, you understand? Your examiner think that a GP definitely know the name of the organism. For that, they have given a microbiologic information. The question is not the name of the organism, rather how it is happening, patient is coming back, could there be any other associated infection? So, Dr. Nasir, again, what will be your answer here? Please, quickly.
Sir, I think most probably B or C, but I think
B or C. You choose only one, doctor, don't choose double.
Yes, it's B, I think.
B. Anybody having quickly answer, you can say. Otherwise, I am jumping. Thank you, Dr. Nasir. So the answer will be chlamydia. So is there a fantastic question, doctor, about the GP? Usually, such patient is going to the GP because GP is very friendly, nearer, and the private issue, they feel more comfort to talk to you, not to specialist or tertiary level. So if patient comes with the gonorrhea, you have given the treatment, is fantastic, doctor. Ceftriaxone 250 milligram intramuscularly. Nowadays, the recommendation is to 500 milligram, though. It's a question collected a little few years early. Whatever. The thing is that the gonorrhea treatment is given, but again, patient coming with the same discharge. It means gonorrhea treated, though there are associated other organisms. So it is said in a STD disease, in the infectious disease, if a person have one STD, there is every possibility of having another disease. We must remember, even this type of patient having the background of unprotected sex, they must be evaluated for the HIV and other, suppose syphilis and other disease also. Okay. So this is the message, doctor. So these are chlamydia, and we need to give the chlamydia treatment. Dr. Nasir, what is the treatment of chlamydia? What antibiotics better? Ceftriaxone is not, or penicillin is not good for the chlamydia. Rather, can anyone say?
Azithromycin.
Fantastic.
Azithromycin.
Azithromycin. So nowadays, in the treatment of gonorrhea, if you come to the detailed topic, you will find the treatment of urethral discharge. If you even have seen the intracellular diplococci, and you see the chlamydia usually not visible by the gram stain. Remember, So chlamydia be seen. You know the chlamydia strip test, the rapid test. So we need to go for the rapid test to identify the chlamydia. For that chlamydia, usually in our regular evaluation process, not visible and not diagnosed. For that, we have given the gonorrhea treatment. So nowadays, the gonorrhea treatment is added with, that means ceftriaxone plus azithromycin, additional azithromycin maybe 1 gram. 1 gram also, 1 gram the azithromycin needed. And for the gonorrhea, azithromycin also helpful. It will be another double dose. And the Infectious Disease Authority now actually evaluating the doses and other. That I told you, doctor, before, that for some common diseases, we must know the doses of the drug as well. Anyway, we are going, I don't know, I am creating some, but I say the intolerance to you, doctor. I'm happy that you are here. A few minutes, it is dedicated for you. So as much as you are here, be connected, I hope you will learn and have an idea of different pattern of questioning in MRCGP. And these are always, I told you also that this knowledge is same, doctor, but patient presentation and the profile of question and answer is different exam systems. So this is a little longer question. In summary, doctor, the 3-year-old baby child presented to you. Baby having the baby become drowsy and the general condition is bad, evidenced by baby has not has not drunk anything since morning. That means mother brought the baby, usually or father. Paracetamol given, patient become lethargic, temperature is still high, child is undressed. You are examining several, you found that non-blanching spots on the lower leg. I think you are thinking one disease. Please raise your hand if you want to give the answer. Clinical record stating that baby having the penicillin allergy, baby was having the rash in the trunk. So you are thinking some disease and your intention to give injection penicillin or medicine as a penicillin. And these rash was resolved when penicillin were stopped. This is the scenario. What may be the underlying diagnosis first, and what will be your plan now? That what medicine you will give or don't give also. Very tricky question, and a GP must know, doctor, this one in the acute medicine headline. Can anybody give an idea, doctor? What you say, remember the word initial, doctor. You are not giving the complete treatment, but initial treatment, what you will do, and you must do it in your chamber. Dr. Faiza, please.
Meningitis.
Oh, fantastic. If it is a meningitis, what medicine you will give, doctor? Faiza, be connected. Huh? So you are afraid to give benzyl penicillin, right?
Penicillin, so ceftriaxone.
Ceftriaxone. Okay. Can anybody have any other opinion? If no, sorry, Dr. Zainab. Yeah, Dr. Nasir, please.
I will refer rapidly to the hospital.
Rapidly, doctor, if you have your car or you will provide a car. Patient does not have the car, the South Asian people is not rich people, doctor. Yes, your idea, you can refer. But even then, for the saving of the life, we need to give one medicine. Dr. Nasir, what you are thinking?
Yes, sir. Initially give some medicine and then refer. I think the patient is allergic to the penicillin. So I think ceftriaxone is the best choice in the given.
Yes, maybe. So I will tell 1 minute more of the decision making, doctor. It's very, very fantastic and very good understanding. If I say, I hope that all of you understand. The GP's responsibility in such patient, it will be life-saving to give a penicillin. And penicillin is the best medicine for treating the meningitis, right? Acute meningitis. So you are not going for, you see that, how challenging for you. You know that meningitis is diagnosed by lumbar puncture, CSF study, acute, pyogenic. But as a GP, how clinical eyes should be developed. By even you don't see the patient, even by reading such question, patient brief, you will be able to diagnose meningitis, especially non-blanching. Non-blanching means purpuric rash, hemorrhagic purpura. See, in such cases, you will not be actually courageous if you don't know this understanding philosophy. The penicillin will be life-saving. In the background, the penicillin allergy history was very mild. You see that? It's just rash and rash is finished, over. Or you have given before or patient was given before antihistamine, it is over. But some patient having the history of severe anaphylactic reaction with the penicillin. So there are two different scenarios of the penicillin reactivity. So as this is the mild rash happened, so you are allowed or you can give the penicillin for the life-saving purpose, because though in our South Asian people not much oriented about, it is for the doctor's bag. I don't know how much you know the doctor's bag. That means GP's bag. GP's bag have some materials, instruments, some life-saving medicine. All medicine are not available in your hand. For that, the penicillin is the number one. Second, penicillin is the best medicine in such patient. So we need to give medicine. If the mild history of the penicillin allergy before, we can give penicillin. But this question will be twisted by giving another background, that history of anaphylactic reaction before. At that time, your drug of choice will not be benzyl penicillin. Maybe ceftriaxone. Second choice will be the ceftriaxone. I think Dr. Zainab understood now. Now come to the decision of that. No antibiotic treatment, rapid hospital transfer. So rapid hospital transfer is very good idea. This is the priority. If you don't have the penicillin now, any antibiotic, so it will be the answer. But no antibiotic is not the answer. So this information actually not completely true. The best thing will be, we will be giving penicillin side by side, arranging an ambulance or transport system for rapid transfer to the hospital. So actually, E will be the best answer if we give the antibiotic treatment and the rapid transfer. Otherwise, the penicillin, main attention of the question is how we are addressing the history of the penicillin allergy. This is the main issue in this question. Okay, doctor, I just took a little more time because it's very critical. I told you the meningitis is rare, but impact is high. For that, this type of questions usually selected, doctor. This we discussed already. The transfer should not be delayed. This is the message. You are not having the antibiotic. You told the doctor, bring the antibiotic, it will take half an hour time. But your ambulance is ready. Then the answer will be transferring the patient to the hospital. So we will not be waiting for giving the antibiotic. Now, agent doctor, a little bigger. So again, the baby. Whenever the baby, they tell about the delivery, immunization, think that it is not mentioned, maybe everything was okay. Now the patient presented with your urology or nephrology. Smoky colored urine, high colored urine, 9-year baby. Previously has the history of sore throat. So 2 weeks before sore throat, now patient developed kidney problem. I think you know who can say what may be the reason. In the pediatric outdoor or somewhere you have experience to work regularly. I think not every day, in the week or month you are seeing the such patient. Post-febrile illness. That means patient have the fever, sore throat, and then after 1 or 2 weeks, baby having the kidney issue, high colored urine. And if it is the urine, you are checking the pulse, blood pressure, and others. So patient had the fluid retention maybe, right? In the leg, the periorbital edema is there. Tenderness in the both loins is there. That means the maybe something inside inflamed. Dr. Faiza is ready to give the answer now. Most likely diagnosis. Hematuria proteinuria is there. Dr. Faiza?
Answer is B.
B. GN. PSGN, in short. PSGN. Other doctor was unmuted. Okay, I think that the same opinion. So let us see now the answer. Just I have shown you a picture here to evaluate the proteinuria and the hematuria. I think doctor for undergraduate level, like me, actually, I was not aware of much about this. In the analysis of kidney disease, urine test, it is said as the liquid biopsy of the kidney. So if possible, I hope I can give you detail in the another class, doctor. If I will be privileged with your participation, kind participation in the lab test analysis class, if possible. So now in the urine, doctor, you see, if in the urine analysis, the proteinuria is the common mandatory feature in the glomerular disease. But if hematuria is added, we say that glomerulonephritis. So it's a nephritic disease. In our patient, the post-febrile sore throat illness, patient having the renal issue, there is underlying immunologic attack. Not time to discuss detail. So post-streptococcal infection, that means the streptococcal infection followed by glomerulonephritis. Why it is glomerulonephritis? Because patient having the proteinuria, almost similarly hematuria. Simply you know it, a little high blood pressure also. So you know underlying undergraduate question, the very bad question, what is the difference between nephrotic syndrome and nephritic syndrome? So this is a nephritic syndrome. So from this patient, doctor, and from the preparation, we must know the clinical features of the disease as well as the knowledge of urine analysis, especially hematuria, proteinuria. So lab test class will tell you some detail also. And the red cell cast is very, very diagnostic for glomerular disease. Red cell cast. So answer will be the post streptococcal glomerular disease. Side by side, doctor, I like to say one thing more. You see the IgA nephropathy. It is also almost same. Post streptococcal glomerular nephritis having the proteinuria as well as hematuria. So IgA nephropathy also having the proteinuria as well as hematuria. So what is the difference? Difference in the course of the disease. Then difference will be here. That this hematuria proteinuria happen not after 2 weeks. This proteinuria hematuria happen at the time or during the illness period. Suppose patient having the fever sore throat in this week, first week, at the 4th or 5th day, patient developed smoky urine and you found that hematuria proteinuria. This is where the diagnostic of the IgA nephropathy. So very, very fantastic difference, doctor. The almost same, but only the difference of first disease and the happening of the kidney problem. It is after 1 or 2 weeks or within the same week of the illness. I hope that I am able to make you understand of this, doctor. This picture is very, very nice picture, doctor. Okay. So now, doctor, come to the next patient. 2-year-old girl brought to see you by mother for the blacked out. You know the blacked out, that is a collapse. For the questioning, having the why collapse? The baby having the tendency for the tantrum. Doctor, who can explain the tantrum? Dr. Nasir, Faisal? Those who are mother now, you have suffering. Now you have faced this thing, tantrum of the baby. Another word is called temper tantrum. Maybe a big word to you. Some baby wants to have a chocolate from the shop, crying, right? You are not giving. A baby is crying, becoming emotional. These are called the tantrum and started crying. And becoming blue and the collapse, fall. So as a mother, you will be worried, right? So mother reports that after the collapse, child seemed to be stiffened, tight for the brief time, and immediately recovered. After a few seconds, become recovered. So as a mother, you will be worried that something happened very dangerous. So child was well before means I told you the delivery history, immunization, growth, everything is okay. Schooling also okay. What will be the diagnosis underlying? So these are very family medicine special question, doctor. It is not very specialist question. And it's very tricks, very simple tricks are there. Can anybody want to give the answer? Dr. Faisal, please. Dr. Sarah here. Yeah, quickly. What are you thinking? A. Breathe, holding, attack. Dr.
Yes.
Sarah also same. Right, maybe. Very, very right. So this is the blue baby syndrome. So blue baby syndrome is important topic in the MRCGP. So this may be one of the blue baby syndrome. But there is some other blue baby, you know, about the congenital heart disease and others. But these blue become again red or normal few seconds after spontaneously. And there is another question, what will be the treatment? So I will not tell the treatment, you will learn by yourself, doctor. For the temper tantrum and the blue baby syndrome. So rather treating the baby, what will be the attention? Treating the mother will be important. The anxiety of the mother will be resolved. This is the glamour of MRCGP. Family medicine, treating other person rather than the patient. So in this area, temper tantrum. And usually it will be stopped at the age of 5 or 6 years, doctor. So mother will be reassured. The some extraordinary pediatric question. Now again, the elderly 63 old, but the urge incontinence. Urge incontinence in the meantime you must know by diagnose what is the scenario. And patient having the hypertension, patient taking Ramipril and rarely drinks water, but does enjoy approximately 10 cups of tea and the coffee. So this is an additional message that patient is fond of tea and the coffee. There is urge incontinence, patient cannot hold the urine well. So what may be the appropriate treatment? Any of you have given medicine for such patient, doctor? Will you feel pleased to share your experience, doctor, that in such patient you are treating and giving the medicine? Anyone? And what will be? Dr. Pfizer, do you like to share, please?
I will go for lifestyle modification.
Lifestyle modification, but answer is not there though. You are right. Lifestyle means what the point of the lifestyle here? For urge incontinence.
Caffeine reduction.
Oh, caffeine reduction, right. If people drinking more water, and advise not to drink more water also, right? Because caffeine producing more urine output. For that, Urge incontinence may have some contributing factor other than these also. Maybe overactive bladder is there. But when we evaluate the incontinent of urine patient, we must address non-pharmacologic address first and the recoverable or corrective issue. You see, urinary incontinence, whatever the types of the incontinence are, distress or overflow, this is a broad headline 3. We must see any contributing factor like UTI, infection, or any constipation. Severe constipation can have a role. And the drug history, you see, drug history, doctor, if you go back, hypertension, patient is not taking diuretics, rather ramipril. But if we are not cautious to take the drug history, we may miss to diagnose well. So if the diuretics, we have to stop the diuretic. So any other diabetes, other we have to correct, including the lifestyle, coffee, tea, and others. And still patient having the urinary incontinence, then we will go for further treatment. Again, in the further treatment, doctor, you see, not the medicine, bladder retraining. I like to highlight to all of you, doctor, in the MRCGP exam, AKT, most of the time, could be a technique, doctor, though it is not very good to say. If you don't understand the option that there are some lifestyle answer, there are some answer of the medicine, antibiotic or other drug. Dr. Faiza, how will you choose the answer? What will be the answer? You don't know the answer, but technically, what you will answer? You don't know my question really?
No, sorry.
I'm talking about this. If you come back here, you don't know the answer here in this question. You don't know the answer. There are some name of the medicine. There are some non-pharmacologic option, right? You don't know the answer. What will be the answer technically without knowing the answer? You can
Non-pharmacological.
yes,
Non-pharmacological answer.
non-pharmacology. This is not the technique for GP in all the question, but more important in the GP because GP, the Royal College wants that GP must know the non-pharmacologic part of the treatment. The medicine and other extraordinary is the thing done by the specialist. So it could be the, you see, caffeine reduction or electrical bladder stimulation. From there, what the simpler one available and patient can do caffeine reduction. If you compare even 2 questions, you have to choose this caffeine. If the water is there, maybe water or tea like that. So it's a thus technical point and technique to give the answer. Yeah, doctor, don't be tired. We are going to end with 2 or 3 questions of the patient, doctor, remaining. Following is a recognized complication of circumcision, right? In some religion, especially in the Muslim and the Jews having these rituals. So, and the doctors are learning how to do the surgery, small minor surgery, circumcision. But it's the recognized complication that it can happen in the circumcision. Can anybody give the answer? Maybe many things you see after circumcision, cancer, recurrent balanitis. Very simple, doctor. Meatal stenosis, right? Is an injury happening here during circumcision. So otherwise, some are actually the indication of the circumcision, not the complication. And it is said that somewhere the penile cancers are prevented by the circumcision. Though not much evidence based, and it is observed that those who are not circumcised, there are a little chance to have the penile cancer, but not a strongly evidence based. So this is a question selected from the surgery. There are some other surgical question from ENT disease, breast disease. So I didn't collect to make the session shortcut today. Female patient, now the female health. Notice a card-like white vaginal discharge. So in the private history, vaginal discharging issue. The most common is the physiologic, doctor, leukorrhea. But this is a card-like. Little different messages are there. What could be the answer now? There is a painful sex also there. That means there is inflammation. Okay, what is the reason of this presentation? Can anyone? Very, very traditional question.
Candida.
Candida. Dr. Zainab and others also. Candida. Faiza?
Yeah.
Candida.
Mm.
Very right. I hope you are near ready for fighting with the AKT exam in November. Right. So this is the Candida. If you go to the Candida, you must know about the trichomonas and bacterial vaginosis also. So this is some clues are there, but my suggestion, what we do for our candidate doctor, we update and customize this box, including the treatment also. This slide will be very helpful for you, doctor. If you feel better, you can make a snapshot here. Remit, doctor, the treatment of the partner needed or not. Usually in the candida, you see partner treatment may not be needed. If the disease is very severe over, then partner treatment is needed. Because one of the sexually transmitted disease. And this is the treatment plan. Again, I like to advise you, doctor, try to remember some doses also. Some doses, though not appeared before maybe, but as a common disease, for that my advice. Antifungal. These are the core message is card like yellow, green, trichomonas. Difference between trichomonas vaginosis and the vaginitis and the bacterial vaginosis. Almost similar, doctor, but no features of inflammation. So this is not the infection, right, by the trichomonas, the bacterial overgrowth of the bacterial commensals. So there is no inflammation, but discharge is there. Very bad smell. Bad smell for trichomoniasis as well. So this is the lead, doctor, and the 23rd. Non-tender swelling in abdomen. And past history, the cesarean section 2 years previous. So non-tender swelling after cesarean section. Okay. And near at the side of the incision. I think all of you understand the answer, right? What will be the answer? At the site of the incision, there is a swelling. Very common. Not common, rather to say, very easy. What will the answer?
Incisional.
Incisional.
Incisional hernia. It is incisional hernia. This is incisional hernia. So you are the GP, but possibly you are not doing surgery. But if you are not able to identify, how can you send the patient to the surgeon? And the danger will be in the hernia. And maybe 2 days before, one patient actually ignored it. She given me the history that she has incisional hernia when I advised for the surgery. Doctor, I don't have any problem right now. I don't need to go to surgery. So this is challenge for the GP to convince the patient, because in future there may be incarceration and the obstruction. So whenever the obstruction, there will be serious, right? So another question from surgery done. Now come to ENT disease, doctor. Hoarseness voice, 3 months. It is not acute, 5 days, 6 days, 3 months. So subacute to chronic disease. And you found that this right-sided ERA there, patient having a stridor, ER is normal, right? By examination of the ER normal. So this is a throat problem. So endoscopy of the upper airway show irregular mass, maybe dangerous, right? Irregular mass in the larynx. Patient is a smoker. What could be the diagnosis underlying? Is that
Carcinoma of larynx.
laryngeal carcinoma? So smoker doesn't mean, if you are given a lung carcinoma, you might be confused, right? Because lung is clear, not mention any lung feature. Rather, pharyngeal features is there. Patient is a smoker. So smoker can cause lung cancer as well as laryngeal cancer. Right? But hoarseness always not malignant. Very common is the cold related hoarseness is recoverable. We practice in our hospitalization also. Laryngitis. There are some singers node popular, hoarseness of the voice. There's some thyroid disease also, hoarseness of voice. So hoarseness of voice is very important topic, doctor. And you come maybe the last patient of today. The most death. This is the miscellaneous question type. That's determined by what? All of the doctor having experienced doctor in your life when you are in the intern, right? Junior house officer training time. You have seen the patient dying and you examine the patient. So we must know. But currently, actually, do we know? This is a question. Which will be the answer here? Determination of the death. Very important thing, what? Dr. Zainab?
Loss of papillary.
Papillary reflex. And Sarah, Dr. Sarah?
Yes, same.
Same. Papillary reflex.
same.
Loss of papillary reflex. Nobody's thinking more. Right. Absence of the vital signs. Pulse, blood pressure. Right? Not only the papillary reflex. Though we are doing we are looking at the papillary reflex, but absence of pulse, blood pressure is the most vital. So this is the vital sign, vital sign, pulse, blood pressure, temperature, respiration. So stoppage of the respiration, pulse, and the blood pressure, no blood pressure. So you see, this is the typical single best answer. Single best answer. In PACES exam, not PACES MRCP exam, it is said that best of 5. So 5 options, all there is a potential to be correct answer. But which will be the best answer? This is expected in your exam. So this is one of the technical point in the question. So absence of vital sign, the combination mode of that. So this is my pleasure, doctor, to be with you today. And this is a break time, not break, we will not give a pause here. That I tried my best to show you some scenarios, doctor, for the exam. And I don't know how much you are prepared for the exam. Somebody may be appearing in the coming. And so my suggestion, doctor, those who will be prepared, have this type of profile. Possibly already you are oriented well. But if anything additional message I have given to you, it may be my pleasure. And my time will be a successful time. So if you have any query, doctor, for any exam related, you can ask now. And I need to finish within 2 minutes. In addition, doctor, in the meantime, you can raise your hand, doctor, to ask me something. I'm just finishing with some finishing slides. We have some topics relevant for the, what I said, AKT exam, doctor. And if you feel better, sorry, I can give you these also, the sharing in the chat box. You can click or copy, or you can send request, doctor, to our WhatsApp number. As here, I have sent to the chat box. You can see the Zoom chat box. These are the links, doctor, just to show you. And the relevant topic may be helpful, doctor. I believe some extraordinary ECGs, X-rays, usually not discussed, and not technical things are discussed even in your learning bundle. In the learning bundle, what you will find, maybe system-wise question. For that, we develop this thing, you can go through. And some interactive questions and other already going, doctor. This is the Telegram again. We are avoiding common WhatsApp, doctor. Some many difficulties are there. If you want to be the interactive member, doctor, you can join our Telegram. This is the Telegram down, doctor. If you can click now also, immediately you can join there. You may even interact with others also there. I know a significant number of participants are there in the Telegram group. And
Sir, can I ask one question?
please, doctor. This is your time, really.
Yes,
I'm just finishing my slide. Please.
Okay, thank you. Sir, I just want to know, will you provide any notes for AKT? And the second is which MCQ pool you provide? You can
Yeah, it's
advise
very tricky
that
question.
past medicine or it's your MCQs, please tell us.
Suppose if you ask me, I can give not only my experience, as we are dealing with the candidates, we can give a summarized suggestion for you. But those who passed, not busy with the group discussion or other, they can give their experience. Somebody find that the past medicine is enough. Somebody say that on exam is enough. Somebody say that past test is enough. Somebody said some other author. But the more popular in the decades, doctor, we passed our exam many years before. In the last observation, when I was candidate, I find the on exam was better at that time. But nowadays, past medicine also developed. Thing is that minimum you need to go through one bundle. Whatever it is the past medicine, whatever is the past test, whatever it is the on exam, not a gross difference, but a little difference in my experience, doctor, for the beginners. I don't like to discuss more. For the beginners, a straight suggestion, start with the past medicine. Okay, I think Dr. Nasir was talking to me. Can you be connected? Easier for me, doctor, to be interactive. Dr. Nasir Khan, maybe? Yeah, thank you, doctor.
Yes, sir.
So past medicine may be the first one. Past medicine have two parts. One is the question system, according to the question. Another one is the basic discussion. There are notes. The notes are important for even for the MRCP exams. So if you want to go through the patient scenario like today we discussed, a lot of questions everywhere, the thousands of many sources. But the development of understanding and what I have shown, the key messages in the patient history is important. I tried my best, doctor, in the marking by the red color. If we are able to understand those type of red mark or the key messages, you will be able to understand the answer of the question. Whatever is the past medicine, whatever is the past test or medicine, not the nature. If you can finish the past medicine, then for the second step, this is our technique, doctor, to provide. Go through the on exam or past test. No need to go double together. Yeah? Don't, which is my suggestion, doctor. You have to busy with your time with other issues, especially now I'm showing a slide you see incidentally that you need to be knowing the X-rays because there's some common X-ray and some ECG questions, some lab data issue, and some clinical pictures also there. So in the past medicine, they are giving maybe some clinical or on exam, some clinical pictures also there. But lab data, ECG, X-rays, till now, so far I know not much highlighted part. So you need to be learning this thing in addition also, doctor. For that, from our side to develop this thing as much as possible, doctor. Don't like to say that we have done 100% for ECG and other. We have maybe 4 sessions in the YouTube. These are free, all of you, and I can share with you, doctor, all the links. Just give me the inbox, doctor, those who are interested, the ECGs and others. So what I was answering the question of the source of the question, past medicine followed by past test oblique on exam. I think Dr. Nasir and all of you understood it. Any further question, doctor? I think no. Huh? Sorry. Maybe. I'm not
Doctor,
tired really. Please, Dr. Zainab.
yeah. What do you recommend for Dubai exam?
Which exam you are?
Yeah, MRCGP, but Dubai exam.
So MRCP, if you are planning, doctor, you have the short time.
No, MRCGP, but Dubai exam.
MRCGP Dubai, you mean?
Yeah.
Oh, almost same, doctor. I have shown in my initial slides. I have collected the message from the Royal College sources. I didn't write by myself. I just customized the presentation. They have given importance of the clinical medicine 80%. Okay. So all the international questions are almost same. Just a little different the UK exam. So I think today participant, mostly you are for the international or South Asian. So you don't find any difference of the exam in South Asian countries like in Bangladesh, India, Pakistan or somewhere, Sri Lanka, almost the same in the Dubai. And many doctors I know that they are appearing in the MRCGP in the South Asian part. In Saudi Arabia, there is an exam center I know. When I was there also, I have seen. For that, Arab people having some difficulties to know about South Asian. But I like to say that this is also not very hard. Very little thing you need to be oriented. Suppose if you go through or discuss amongst other, 1 day is enough to know about a local diarrhea problem. Even the Gulf country people having the diarrhea. Some ARI, upper respiratory problem. Immunization schedule almost same. So doctor, don't worry about the Dubai exam. Don't worry. Whenever you are preparing with, even the learning bundle actually we are using from the UK bundle, doctor. You know, past medicine other, they didn't develop much. Almost same. So learning material is same for the UK and outside UK. Maybe past medicine on exam of the past test. So core things are same, doctor. Don't worry. You go through and prepare by yourself. Now my urge, doctor, to you. If you feel better and until you have heard, we like to actually do the classes of these again. Maybe though they are having some classes on the YouTube. So definitely the next topic will be updated one. Anybody want that? Which better to choose from here? Anybody? Can anyone suggest, doctor? For your benefit. If you suggest it's better for us to choose the coming day, any other time, doctor. If you don't want really, we will not do anything.
I think
right?
clinical picture is.
Picture class. Okay, doctor. So I hope that in the coming days, keep your eyes with us, doctor. We will select another day. And if you ask that what we are doing, doctor, this is actually, you have seen maybe the preparatory time. Some of you asked that when we are studying. So we are planning to soon start the basic classes or even the exam. Actually, in our exam is not restricted for the time. It is an exam like the mocking, especially important for those for appearing the exam. But for the basic development, doctor, this is our 12 class basic classes, the live interactive like today. Maybe I'm sorry, possibly I have given that 11 September one of a possibility, but those who are busy with the OSCE preparatory doctors coming October exam in the Sri Lanka. So we are very busy with them. Every day we need to give a session for them. So I'm sorry, we need to defer the day of the September, maybe at the end of September or the first part of October. I will like to say that the basic course, those who are very rapid to having understanding, those who are lacking in the preparation, you may get some benefit, but plus you need to go for the exam. I'm giving an example of mentoring, right? You may do it for your any other sources with, no problem. Thing is that you need to know about the basic ideation plus exam preparation by mock exam. If you don't appear at the mock exam, you will not understand how exam is going on. Suppose in our package, only 2 exams are there. We could not do much more, right? 200 question, doctor. We need to screen many questions, repetition, selecting the system. We have even a lot of time to prepare. So there are some system examination. It will be helpful for the system wise. If you go through one system and then test yourself by examining, there may be around 40 questions for each system. There are 12 system plus the final 2 complete mock, 200 plus 200. So in time bound situation, you have to prepare, especially maybe Dr. Who is there? Zainab is there, you know, you are appearing maybe in the coming time. So far I can remember. So it will be the advice for you that be serious about this, especially this part is very relevant for appearing the exam, the mock exam. Different mock you can appear, doctor, not ours from the dorms, I like to say. You can attend many other mocks. If you find that is good, like today's, we are dealing this by marking the core message, doctor, in each question. You will find, or minimum, we have given the exam in the explanation and which the message of the patient be more attentive. We tried our best to highlight this. This is our tendency and what we have shown today also. In the mocking also, you will find there may be the question and the answer script. Answer script means explanation with the answer as well. And this will be live class, doctor. Actually, dependent upon in the coming day, we will set. If those especially who are not appearing may be very helpful. Even who will be appearing in the November also, if you want to have a rapid understanding of the basic thing, you can join with us, doctor. Maybe the first week or first part of the October. So November middle is the exam date. We will try our best to finish 12 classes in the 2 weeks time. Every day there will be class, 6 class in a week. In the night time, not this time, maybe UA time will be 8:15 p.m. in this October month. Because we will be finishing OSCE earlier in the September or the first week of October. So this is our part, doctor. It is my privilege to share with you. And we designed this way, doctor, the 12 class like that. You see that the X-ray and these are not mentioned especially here because it will be an approach course. So X-ray ECG you need to learn in a separate part. For that we kept it open in the YouTube, our previous lecture. If you go through it, it will be enough, doctor, for you. So the basic class with some pre-reading material, it is called the pre-reading. You can read by yourself. And we will be providing our learning material for you, our learning material for there. And I think I like to finish now and thanking all of you. If I made any embarrassing for you, doctor, to keep you connected, I don't know how much you have benefited. I'm sorry for that, but I believe that a few minutes you are with me, more or less you have benefited, doctor. It will be our pleasure if you have benefited. I like to thank you, all of you, doctor, and our WhatsApp, even the Telegram is open. Especially we are communicating with the WhatsApp. You know already the number. You can come in contact with us, doctor, for your further preparation. So thank you very much, doctor. Thank you.
Thank you, sir. So nice of you.
Welcome, doctor.